Nico, what's up, my man?
Josh, how are you, brother?
I'm good, man. Listen, for those who are going to listen to this, they don't realize that we've actually already done this once before, and here we are again, round two.
We couldn't have enough of it, right?
I know, right? I always like to give people a little bit of a background. You and I met at the Silverback Summit with Allie Gilbert. Heard you on stage, super impressed by not really just your knowledge. I mean, I was very impressed by that, but just the way you carried yourself, the way you've come across humble. You have this deep desire, I can tell, just to help people, and that's an area for me in medicine that really, really matters, is to watch people, the way they carry themselves, the way they're looking to serve other people in how they, do their business. And so I was super impressed by you from that event. And so thank you for taking the time to be on the podcast, man.
Brother, it's a pleasure. And thank you for the kind words. It was such a pleasure to meet you and get to meet some of your team and stuff like that. So I'm humbled to be here.
Yeah. Tell us a little bit about you. Let's just give a background of, why we want you on the Rebellion Health podcast, what you do with hormones, how you got started, what you're doing currently.
Absolutely. I'm terrible at summarizing. So first of all, my name is Nico Misleh. I'm a family nurse practitioner by trade. My background has mostly been in, what I would consider integrative and functional medicine, and probably even beyond that. But I've really cut my teeth early on as a nurse. My grandfather was a physician. He's retired now. He's 95, and he just gave up his medical license because apparently he's not going back into the hospital anytime soon. But he told me don't go to medicine. It just sucks. He had to live through the big insurance and big pharma and the oxycodone crisis. He owned his own clinic, and did the whole clinic ownership of the 90s and just said it was awful.
Yeah.
So it hurt my feelings because I always wanted to do something like that. And so anyways, I was really lucky to have met someone to say, hey, go into nursing and then just become a nurse practitioner. You'll love it. It's an amazing career opportunity. And I just sank my teeth into it, and it's been amazing, truly. Early on, Josh, again, probably because my grandfather gave me that little bit of like, hey, if you're going to do this, just don't do it this way. I quickly realized I have to find other methods of how do I provide care? How do I do it so that I'm not broke? And all that kinds of stuff. So, I started getting into, looking at functional medicine clinics, and they were mostly integrative medicine clinics around me. Functional medicine kind of came a little bit later, I would say, but I met these amazing, mostly docs, a couple NPs who actually own their own clinics, and they were impossibly hard to find. And they'd been doing this for years, and they just, took me under their wings. They were so psyched that this young kid was like interested in all the stuff they were doing. The one doc I worked with, he was doing hyperbaric oxygen therapy, methylene blue IVs. You name it. HRT, he'd been doing it for 30 years.
Wow.
This was 10 years ago. So he's one of the guys who, really was a total frontiersman in that world. And again, he was just so jazzed that this young kid actually thought he wasn't a total crackpot and wanted to hang out with them. And I adored him. I really did. And many other, again, mentors as well. But so I just always tried to position myself in those scenarios and situations. And, I got to watch these people interact with patients in such a different way. Because again, I'm in school, I'm doing all the typical urgent care and then women's health and pediatrics. And, it's cool. And I'm learning stuff, of course, but it's just, treat and street, 5-minute appointments. No one's getting better. Everybody's,
right.
I'm seeing the same patient over and over again. They're getting worse and worse and worse. Then they end up in the hospital and then they come back. And so it was a really weird paradox where I'm involved in medicine in this aspect of conventional side of things, and then in the other aspect on this very holistic side. And I quickly realized, wow, we are way, 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 way behind on the conventional side of things. And so again, I was really lucky. I graduated. I said, I don't want anything to do with, I didn't want to spend a single day inside another, quote unquote classic clinic. I convinced a nurse practitioner who owned a mental health practice. Again, it was technically a very traditional psych practice, insurance based, all that stuff. I said, hey man, I want to do functional medicine. I want to attempt to treat psych patients via functional medicine. Wow. Can you let me do that? And he was like, sure. And I made no money for like 3 years. I saw these, I'm having these hour-long appointments and they're looking at me like, dude, what are you doing? Like, you're not going to get paid anything. But again, there was another great opportunity to just be in the thick of it, to see both sides of mental health with all the psychotropics and stuff. And then me over here trying to use vitamins and then, of course, hormones. And Josh, that's ultimately where I got really deep into HRT. And it started out mostly with women who suffered from premenstrual dysphoric disorder, which is, colloquially speaking, it's like a PMS times 1,000. And these poor women, they're, put on birth control or an SSRI, and they just never seem to get any better. And it actually makes a lot of things a whole lot worse. And I had one gal see me, and I immediately recognized, like, okay, I know I'm reading about what this is. This is not a SSRI. This is not a serotonin problem. This is clearly a hormone problem. So let's apply hormones. And we started working with her, and it was just amazing the turnaround she had in like 3 months. It's amazing. And then she told everybody and their grandmother who ever had PMDD to come see me. And then I started treating guys with PTSD, with oxytocin, and again, all these just variable hormones. And I just became the HRT guy all of a sudden, like really quickly. It was just go see Nico. He'll put you on HRT. And then I spun off my own clinic, which is now Apollo Health Optimization, where we really, again, our bread and butters, hormone replacement therapy for men and women, but we also, do a lot of peptides and weight loss and all that kinds of good stuff too.
Yeah. So, okay. So Brett, similar, story there as far as, what's the makeup of what you do from a practice standpoint. I always tell people the bread and butter, our foundation is in hormone replacement therapy. I would argue that hormone replacement therapy in today's world, right? We use this term biohacking. I think hormone replacement therapy is the original biohack. It's the greatest biohack. There's nothing out there. I don't care what peptide you're talking about. There's nothing out there that truly biohacks it in that term like hormone replacement therapy when done appropriately. And so I love the fact that you're, that's become your focus. Talk to me a little bit about, I'm thinking about, as you're telling me that story, right? These mentors who, again, they were perceived as quacks, right? So 10, 15 years ago, people really even dismissed them. Nobody was talking about methylene blue and, ozone therapies and things like that. What's interesting to me is that, I started my practice about 4 years ago, and even 4 years ago, that model, people were doing it, but not a whole lot of buzz, right? But you fast forward to today's world, and now, it's like, for me, and I think what you were saying is that system that we both came out of, that traditional healthcare system, I perceived that when I started my practice, because I'd worked in it for 11 years, as like that was my quote unquote enemy, right? I was advocating for patients to identify this system is broken. It was never meant to make you well, but rather keep you sick, treat them and street them. And I lived that world for a long time. And so out of that came my heart to do what I do. But what I've learned, Nico, and I'd love your opinion on this, is we've now shifted to where there's another problem, and I refer to it as noise. And what I mean by noise is because now you have where methylene blue was never talked about, now you can't go on your social media feed without being inundated by influencers who are promoting methylene blue and, methylation testing. And it has come to feel like it's a little bit of a money grab. And so for me, I think the audience that I want to attract is the people who feel confused, right? They're like, man, this system feels kind of broken. I know I can't look to that system to get answers, but this feels overwhelming over here, right? I don't know what to do. And so I would love to hear your thoughts on that and just what you see in your own clinical practice and those conversations. Because for me, I was telling somebody earlier, when I first started, I might have 5 conversations a month about peptides. I probably have 5 conversations a day about peptides. And and again, where is that information coming from? It's coming from social media. It's coming from all these influencers. So I just love your thoughts on, just kind of the overview of where we're at in medicine.
Yeah, well, I appreciate that, Josh, and I couldn't agree more. I first and foremost, I agree. I think HRT is probably one of the most foundational things we can do for people, and I think that's quickly becoming more and more obvious. I think it's funny because I saw the same thing in functional medicine. I had one mentor in particular who, again, another guy who I loved, and he's still practicing today, and I love him to death. But he was a very old school functional med guy, which meant there's a supplement for all of your ills.
Yeah.
And you'll end up with this laundry basket, literally, of, could be 100 supplements that you're going to take 12 times a day and this, that, and the other. And so I also saw the downsides of that world of holistic care and functional medicine and stuff. And their approach was even more so. His was like, we don't need HRT at all, right? Just take your ashwagandha and take your valerian root and this, that, and the other, and you'll be fine. So again, I'm always searching for where is that balance? It's such a fine line where we're just, you can out diet and out, supplement everything, versus no, we'll just give you that one medicine that'll cure everything. And then at the same time, we'll give you 5 more because it's going to cause, 4 other problems. So I think that in today's age with the social media stuff, I try to give people some guardrails. I think the most helpful thing is, and I know it's obvious and almost silly, but get off of social media a little bit.
Yeah.
Especially the short form stuff it's just useless. The amount of people I hear, just like you do every day, who are talking about methylene blue and progesterone. I mean, there's a video, I just talked to my community about this recently, a video by this well-known physician who talks, she's kind of a hormone guru, and she was talking about how dangerous oral progesterone is, and it's like a benzodiazepine, and it's going to ruin your cognition. And, all these providers are coming to me saying, Nico, I don't know what to do. I gave all my females this progesterone. And when you really just step back from this 30-second clip, what you realize is, number one, she's just conjecturing meaningless nonsense. It's an attention grab. Yep. If you really understand the principles and foundations of what progesterone is, how it works in the body, some of the mechanisms behind it, you would quickly realize, and especially if you understand the randomized controlled trials, none of that's true. It doesn't actually exist in real life. Now it's an interesting conjecture, sure. We all of us do that, but those are the kinds of things. So I try to tell people, avoid the short form stuff, especially because, again, you're going to take a lot of stuff out of context. If it's not a 2-hour-long podcast or an hour-long YouTube video, it's probably kind of useless. Yeah. And then become students of what you're trying to learn. Now, I understand for patients that's not always so easy, but try to, as best you can, work from first principles effects, right? Okay, if I really understand what this hormone is, not even just beyond human beings, what does progesterone do in animals and mammals, and right? What was the origin story of progesterone? It just helps give you a little bit more ground to stand on than just, again, Dr. So-and-so said that it's dangerous and she's a doctor, so, it must be true. Yeah. I think COVID broke that 5 years ago or whatever it was, which is awesome. I think, again, it was funny. You're so right, Josh. I'm talking almost 12 years ago when I started being mentored by these amazing physicians and NPs who were literal quacks. I mean, these guys were thought of as just dirt when they came to providers. They were nut jobs. Everything they did was conspiratorial. And now they would be like RFK pedestal, giants among men in just a matter of 10 years, So you're right. 5 years ago, I was a total quack. And then COVID happens, and all of a sudden now I'm like, oh, Nico's kind of cool, and he's pretty interesting. And, so it's funny, but I always said, I didn't love COVID. What I loved was that it broke some of this system up and all of a sudden turned those authority figures into people who are like, he's just a guy or gal like me. Yeah. And I'm not always that smart. I don't say the smartest things all the time. We're all just trying to get through this together. I better become my own advocate and a student of whatever craft I'm in, and certainly try to become a student of others who understand it.
Yeah, I love that. Let's talk about some of the things that we commonly see and maybe even not so much commonly see, perimenopause, menopause, PMDD, PMS in women. But I think this would be a really good conversation to talk about some of the myths, right? Some of those questions around, I'm just going to throw one out. Which form of estradiol should a female use, right? Yeah. Again, social media tells you one or 50 different thoughts. I'd love to hear your expertise, your opinion on, as you've looked through the data, you've educated yourself, where do you see the female, when it's appropriate, has the best bang for her buck if she's going to use estradiol?
Yeah, it's such a good question. The most honest interpretation I can bring to those of you who are interested in estradiol, or maybe you're taking estradiol. So remember, estradiol is the major female hormone. There are many different ways of essentially taking this medicine. You can inject it. You can take it orally by mouth. You can apply it as a patch. You can apply it as a cream or a gel. So again, there's a lot of different roads to Rome. Everybody wants, of course, to know what is the best route, which is a whole different question than what is maybe the most convenient route. But at the end of the day, what essentially became this very common trope was that oral estradiol is the devil. It causes clots. And so the only reasonable estradiol to essentially utilize is anything that would be considered more on the topical side. So creams and patches and gels and stuff like that. Because it does something specific. It bypasses what's called the first pass effect, which is in your liver. And in theory, it doesn't turn on all these clotting factors. And that's why we see lower rates of clots in topical estradiol. The problem became we were making associations and almost turning them into what we call causations. And that becomes a very mired, mucky mess. But when we really evaluate the literature, what a lot of providers and even patients misunderstand is, first of all, a lot of times when we're talking about estradiol and clots, most of that is coming from a fear of something called conjugated equine estrogen, or CEE, which most of the studies reflected did in fact increase your risk of clots. This is why if you take, combined birth control, you're typically told, hey, you might not want to smoke or anything like that. If you have a risk of clots or you've had one, you're probably not going to be able to take this. Bioidentical estradiol, which is the estradiol that you and I make and any other female or male out there make internally, when we take that molecule and we ingest it, practically almost any way possible, it doesn't have the same effect. So that's a huge, huge, huge myth in and of itself, is just the type of estradiol. And again, we're comparing literal apples to oranges there. Right. The stuff that you're getting from Walgreens is not even a hormone. It's a fake thing that you're putting in your body, and your body doesn't really know what to do with it. The other aspect to that is, even if we're talking just oral bioidentical estradiol, in the randomized control trials, we have never seen an increased risk of clots. Right. In the large observational studies, we've never seen an increased risk of clots. There are a few smaller studies where they saw, literally what would be statistically insignificant levels of clot association. But again, association, not causation. When we combine, this is where it gets really interesting, when we combine bioidentical estradiol with bioidentical progesterone, which is in essence how it always should be consumed, we, practically speaking, never, ever, ever see an increased risk of clots. So, and again, a lot of that is understanding that estradiol is very proliferative. It's very pro-inflammatory in a lot of settings without progesterone. It does, in fact, increase clotting factors without progesterone. All of a sudden, you add progesterone in, and all of those really negative things tend to float the opposite direction. Now we have low risk of clotting factors. Now we have an increased positive output in terms of mitochondrial function. So there's all these amazing things when you just understand, again, the principles of each hormone and then how they interact with each other.
So I love that. And one of the things I think, let's come back to on this, is you talked about estradiol alone or without progesterone, which is not an uncommon practice for providers to prescribe women who do not have a uterus, right? The common practice historically has been, if a female still has her uterus, if she's doing any form of estrogen, she's going to have some form of progesterone or progestin back in the day. But I've seen this in my practice where I'll put a female who's had a hysterectomy on estradiol and progesterone for the reason you just mentioned, they'll go to their GYN for their annual, and they will tell them, why are you on progesterone? That only benefits your uterus, and you don't have one. And so it's so short-sighted. And I love how you just talked about that. So this is really more for the ladies listening to this, is that if you have had a hysterectomy, you are not excluded from being in the conversation that progesterone has great benefits from an inflammation standpoint, from a neurological standpoint. And so I just love what you're saying there, but I think it's really important because a lot of women have that narrative and they're told by their PCP or their GYN that, well, yeah, you could take progesterone, but you don't really have a uterus, so you don't need to.
It's so silly. Talk about one of the honestly one of the biggest myths out there. Right, is this idea that progesterone is just for a uterus and that's it. It's only for pregnancy purposes and reproductive purposes, and beyond that, it's this useless garbage thing that just floats around our bodies, which is so crazy because that would not be dissimilar to, practically speaking, any other hormone. Like when we think of sex hormones, yes, does testosterone help a lot of things in terms of males having erectile quality? Of course, but that is like a small portion of what testosterone does.
That's right.
If you take testosterone away, your muscles shrivel up, your brain goes to crap, your heart, becomes totally defunct. So I can't imagine why we would consider progesterone, insulin, whatever. If we take something away or make it deficient, it generally speaking affects the entire system. It's not this isolated thing.
So talk to us about your, again, I'm thinking about formulations and serum levels. There's different ways to measure labs. We've talked about this before. I'm a fan of serum or blood draws. It's cheap. It's been the most studied. It's well established. But in those patients where you've got them on estradiol, regardless of formulation, I find that it's really hard if you've got a patient who wants to be on a transdermal. I find it really hard to get a serum level in anywhere close to 80 picograms per millimole. Very hard. So what levels are you shooting for on the preventative side, not necessarily symptomatic, but on the preventative side? And what is the preventative measure that you're actually trying to prevent?
Absolutely. So specifically when it comes to estradiol, and we have some understanding of that when it comes to progesterone too, less so with testosterone. What we do understand is that in most of the, whether it was a randomized control trial and mostly these large observational studies, we're talking thousands and thousands and thousands of women, what we would typically find out of those studies is that most women benefited the most from an estradiol serum value of at least greater than 60 picograms. So again, there are other studies that say 75. I've seen some, that suggest maybe 80. So, but in general, what we're looking for is at least greater than 60.
Yeah.
And what they found with that was especially more so on the front of osteoporosis and cardiovascular disease risk mitigation.
Yeah. When you talk about that level, do you have your patients skip their dose for labs, or do you have them take their meds for like the day of?
It's a good question. People always ask me that. Are we checking for a peak or a trough or things of that nature? Generally, I'm looking for a trough because even if I get a trough of, let's just say it comes back at 45 picograms, and this woman who's sitting across from me reports she no longer has vaginal dryness. Her depression symptoms have lifted. She has amazing libido again, yada, yada, yada. I clearly understand that the estradiol is doing stuff. Likely when it's a peak, it could be 100 or so, right?
Yeah.
So the fact that let's say 12 hours or more later, maybe even 24 hours later, we're getting a trough that's in the 40s, that is still sufficient enough for me. And again, I like to make that very clear to my providers and students and even patients. Just because serum estradiol is 45 at a trough also does not mean that you're getting zero benefits.
That's right.
The benefits just happen to be really highlighted on that bell curve around, between 60 and 80. But you're right. A peak value, again, the minimum ought to be probably 75 or 80 because I don't want it dropping to practically zero.
Yeah.
I want most of the time that woman to live in a spectrum of this is a really good level.
Yeah. Well, it's funny. I was running behind on this podcast, and literally the patient I was trying to, take care of, her peak 3 months ago on her estradiol was 87.5. And today's level, when I looked at it, was 44, right? And this is what's really important, because patients don't know to ask this question. And oftentimes, again, they'll go to their, PCP or GYN and say, oh my gosh, that estradiol is too high. But the importance, in our clinics, one of the things that we always do is we have our phlebotomists document when was the last time you took your medications. Because my joke is I can make your level say anything I want, right? I can tell you to skip it. And I think there's this model out there where a lot of places want you to have the trough all the time. And I think that's fine as long as you understand like what you were talking about. But it's almost this justification of, well, it justifies that you actually need it. And for me, I kind of have a different approach where I like to see both peaks and troughs, because I want to know if I'm going to manage you, am I actually managing you at an optimal level? So I think those peaks and troughs are very important. But again, I've had so many conversations around that where patients will call me and say, well, I went to so-and-so and they said my estradiol was too high or my testosterone was too high. Did they ask you, when did you use it, right? Testosterone, I think, in women is very important to have that question, because again, I can show you a peak draw on a testosterone cream of 200, 300. And if they come back at 8 hours later, that level may be 60. Well,
right.
What do you do, right? Do you say, oh my gosh, that level's 200? And I see that all the time. And so let's talk about anything you want to add there. But then I'd love to also kind of talk about the idea around testosterone in women and where, what you look for there, why it's important. Hopefully more and more women are going to have access to testosterone as if it gets FDA approved. But yeah, I'd just love to hear your spiel on testosterone in women.
Well, first of all, the first thing, you're so right. I mean, I always try to remind my patients and providers who I teach, like, look, when we say your estradiol is too high, based on what standard?
Yeah.
What standard of what? What do we mean by based on the normal reference range? What do we mean by normal? Normal how? Like what are we implying there, right? So again, I have patients who, I get their estradiol, let's just say whatever their peak value comes back and it's 80, and they feel like dog shit. They feel awful, and in fact, any higher it just makes them feel worse and worse and worse. And in fact, they need to be right around 45. For whatever reason. Now, does that woman miss out on all the amazing benefits? Well, no, because every part of her life is improving when she's at that dose. So that's where it always, and again, speaking of other, urine analysis and all, look, it's all interesting, but we have no standard to base this on.
It's so good.
So, and that is where testosterone in particular, you're so right. Testosterone is incredible for females. It is so vital and necessary, the same as it is for us. Mm-hmm. I mean, it is literally no different than like I make insulin and so does my wife. Now, maybe as a dude, I make a little more than her, but like, does that disqualify her from needing insulin at some point in her life just because normally it would be zero? It's crazy.
Right.
Again, when it comes to total testosterone values, which again are not the best metric necessarily, but let's just take them at face value. Total testosterone being how much testosterone do you have in your system right here, right now. When we put women on testosterone, the arguably, I think the best clinical analysis we have right now is, not a smaller study, but I think it was several thousand women. The range of quote unquote optimal symptom resolution was somewhere between 150 to like 350 nanograms per deciliter. It might have been, and it's definitely nanogram per deciliter. And the normal reference range for, say, a 35-year-old female right now is like 0 to 60, or 7 to 60, depending on the lab you go to. So that in and of itself should tell you this is all hoopla. Like there's this is not based on any standard other than a bunch of scientists in a lab said, okay, we pick these numbers because we took this group of people and that's just the bell curve we found. So again, for my female patients, I have some who need way less testosterone than, again, what that study shows. Yeah. I also have I have females who have a total testosterone of 650 nanograms per deciliter.
Right. Me too.
And that's the only way they feel better. And of course, we can talk about SHBG and free testosterone. But what I'm driving at here is, and again, I can feel where this might feel so confusing to patients and providers, because it's like, well, then how do we know? Yeah. And I think that's the wrong question to some degree. I think the question is, are we utilizing these labs to give us some frame of guidance and reference That's why we call it a reference range. It's just can we use this as a guiding light? But at the end of the day, I'm going to use my own knowledge and skill set and understanding deeply of these hormones to provide great outcomes.
So good. Yeah. And to your point, free testosterone, which is the availability, right? It's what's accessible to the cell, is 1 to 3% on average of a total. And so if a female has a total testosterone of 450, but she has a high sex hormone binding globulin, albumin, well, her free testosterone may be 3, and she may not feel well, right? And so having the clinical acumen to understand that it's not this cookie cutter approach and say, well, you got to keep them in this range. Says who? I love what you're saying, because one of my common responses when patients ask me, or if they've come from a different provider, is tell them to show me the study. That's all, like I'll bow down and say, you're right, I'm wrong, but just show me the study where you have that ability to tell me that this is the way I'm doing this is incorrect, because I don't think that exists. Which formulation of testosterone do you prefer in women? Are you a cream guy? Are you an injectable?
I like both, frankly. I would say in my clinic, initially, so, let's say 3 or 4 years ago, especially when I was really heavy into it, creams were just so much more popular and common. But I probably have at least almost a quarter, maybe close to a half of my female patients, especially the younger ones, tend to opt and prefer testosterone cypionate, which would be the injectable version. So great pluses and minuses for both. Again, I try to tell my ladies one is not necessarily more effective than the other, so much as it is just somewhat a personal preference point and how you're going to respond the best. I have some ladies who we need to split the dose of the cream, right? If they're just doing once daily, it just can be a little too much all the time at once and then not enough later. And that's, again, where we find the injectables 2 or 3 times a week, we tend to just have a little bit more steady levels.
Yeah. Yeah, no, that's great. I would say our practice is about the same. I'd say 75% is a transdermal cream and 25% is probably an injectable. And sometimes we'll microdose that to twice weekly injections and really try to dial it in to where there's not a huge peak and trough. So yeah, I think that's a very reasonable approach. Let's move over to guys for a second. I know we got just a few more minutes.
Yeah.
Talk to me on I think guys were a little easier. There's not as much complexity, but I think there's still some myths out there. I had a conversation with a patient today about his red blood cells and his hematocrit. So what should guys be looking for when it comes to testosterone? The common myths, my blood is too thick, so to speak. Where does that come from? Is there any validity to it? I know the answer, but I want you to share that.
Oh, such a good question. And another really mired topic, but more or less there's an idea that when a man is on testosterone, really any version in particular, whether it's creams or gels or injectables, that men will succumb to something that is classically referred to as polycythemia, which is just an increase in red blood and not red blood cells, in all cells, right? Poly meaning many, cythemia. So the idea is, and this is what we see even in the clinical literature a lot of times, is this word polycythemia getting tossed around, which is not a great thing to have.
That's right.
It's usually a very dangerous pathology, and there's many things you'd have to do to correct for that, and hematology and whatnot. But to help you understand, if you're just new to this, what testosterone does do naturally, so the testosterone that I'm making in my body right now and you're making in your body, does something called erythropoiesis. It basically helps tell the body and the bone marrow specifically to produce more red blood cells. That's a very important thing that the body does every single day. Now, erythropoiesis in general can be stimulated by a whole lot of things. So if you live in Leadville, Colorado, and you're maybe 9,000 feet above sea level, your body is going to be starved for oxygen, and it's going to purposely say, this is not great. I'm going to bump up my red blood cell production so I can carry more oxygen around my body. And in order to do that, I'm going to increase my erythropoietin, or this chemical that will help stimulate that. So there are other things that can cause that. Sleep apnea is one of the most common things that we see cause what we call something secondary erythrocytosis, meaning there's something like living to 9,000 feet above sea level, or maybe I'm choking because my airway is really small and I'm really overweight or something like that, and I have obstructive sleep apnea. And again, my body is forced to say, boy, I'm just so hypooxygenated. I need to produce more red blood cells. So again, testosterone, technically, testosterone replacement therapy, since we're injecting it from the outside in, that would be classified or ought to be classified as secondary erythrocytosis. That is inherently not a dangerous thing. And this is what the literature has finally had to just lay down and say, okay, yes, when we are looking at erythrocytosis caused by a pathology like obstructive sleep apnea or COPD or something to that effect, that is not great. And it is probably going to lead to dangerous things like clots and strokes and heart attacks and so on. That is not true if you live in Leadville, Colorado, and you're very active and you're, perfect BMI and you bike every single day and your hematocrit comes back. I'm sure you've met providers, but I have a good friend of mine who lives in Colorado, and his patients, almost all of his men come in and their hematocrit's above 55%.
Yeah.
Right. So again, that would be a number that would scare most doctors here in Cincinnati, Ohio. They'd be like, holy crap, why does everybody have such high hematocrits? But in Colorado, that's just a known thing. Same thing with testosterone replacement therapy. Just because we see an elevation in a particular number on a lab, it does not inherently mean or associate or cause a pathology. In fact, this would make perfect sense if you're, again, training for the Olympics. You would go to where? Somewhere really high elevation like Colorado in the mountains where the Olympic Training Center is, to naturally increase your red blood cell production so that when you go to Brazil 2 months later and the Olympic Games, you're actually at a slight advantage. And again, we see this is what guys do in Tour de France. They take erythropoietin or EPO to purposely push red blood cells up. So anyways, I hope that answers some of that question.
Great, man. Yeah. Because I think that what I tell patients a lot is in medicine, we like to have absolutes, right? We like that black and white level, and so you can go back to the Framingham studies and you can show some of this baseline data where hematocrits, like to your point, associated more with, obstructive sleep apnea, COPD, not on testosterone. And I would even make the argument that those patients are at risk for clots, not so much because their hematocrit's elevated, but because they have an inflammatory issue, right? Their body is pro-inflammatory. And so that's why I don't think you see it on the same interventional data around testosterone. And I did a fellowship with Abraham Morgenthaler a couple of years ago, and it was fascinating. Incredible guy. I think the world of him. And one of the things that we talked about, I remember asking him this question. I mean, this is a top 5 andrologist in the world, right? A lot of things that we practice now comes out of the fact that he was spearheading 30 years ago. But one of the things that I asked him was, is there a study that I'm not aware of where to this point that maybe I'm missing something and I want to know? And he's like, no, there's not a study. There's not a single study on an interventional standpoint where this is ever shown. We know that it happens. 70% of men are going to experience erythrocytosis by most, meta-analysis that I've looked at. But from a standpoint of, does that equate to harm? The answer is no. That has never been shown in a study. And so I love having this kind of conversation because I think this is a very common thing that I see in our practice where, again, PCPs, they're all, I hear it every day from a patient where they said my red blood cell count was a little elevated. So I love that. In your practice, are you, with men, would you say it's probably the exact opposite on injections as far as probably 75, 80%?
Certainly. Yeah, certainly it is. And again, ironically, I don't know if it's this way in your practice, but it tends to be the younger the guy, the more apt they are to pursue injections versus like the topical stuff. And then usually when you hit sometime in like your 50s, early 60s, you're like, forget this stuff. I'm going to move to topical creams. But I mean, frankly, I'd probably say, maybe 30% of my guys use topical. And it's great. It works awesome if you know what you're doing. It's great. Yeah.
Compliance is the issue.
It is 100%.
Yeah, compliance is the issue. Amen. Talk to me a little bit as we kind of head off. What your passion with HRTU? Who is that audience that you really are targeting that you are trying to add value to? And how do people find more about what you do through your clinic or through HRTU? I'd love for you to share that.
Well, thanks, man. I appreciate that. HRT University, or HRTU is what I'm wearing on my shirt today, is one of my pride and joys, outside of having my own clinic. I had this calling, I think, literally, I think it was a God thing to some degree, because it's always been deep in my bones to educate and to teach. I love it. It's just my favorite thing in the world, but frankly, to talk about anything, but especially HRT. And I started getting more and more opportunity. I started speaking, locally, regionally, nationally on HRT and mental health and all kinds of things. And providers started wanting to come in and let me come train with you and let me learn about HRT and some of the business stuff. And it quickly snowballed into, wow, I think a lot of people really want to learn this stuff and learn it in a way that, again, is unique. And so, one of the things that we pride ourselves on with HRT University is that it gives people a framework. Right? We have like a first principles type of, again, we don't present it like it's this boring philosophical thing, but we really allow providers to jump back into the basics of metabolism and mitochondria and how do hormones interact with that? And why do we give hormones, right? What is the purpose of this?
Yeah.
What is it beyond just okay, sure, it's great to help guys and their erectile function and women and their bones, but why else do we give HRT? And, selfishly, I've always said, what testosterone replacement therapy has done for me, I wish I'd started taking it 10 years earlier. I wish I would have had someone like me give me the opportunity to do that. And so deeply for me, for my own, I have 2 girls, and I got one on the way. And when they're out there in public, in the community, wherever they go, I hope that they meet patients who are at the top of their game, the best versions of themselves. And I hope when they go to Tennessee, they meet people who Josh treats, and someday if they need help, they'll get the help they need and not have to get spun around by their primary care or be gone. So again, the HRT University is really dedicated to helping providers across, whether you're an MD, a PA, a nurse practitioner, doesn't matter. It is really dedicated to helping people really understand the depths of it and being able to apply that effortlessly and being able to think through those complex cases or those questions that patients ask that keep you up at night. We want to give that to you, and hopefully that again lives on in a way that again is just bigger than you in general.
Yeah. Love it, man. If you're listening, check out HRTU, HRT University. Nico is phenomenal. I mean, you literally just got a snapshot of a 45 minute, video of the knowledge breadth that this guy has. And Nico, it is an honor to know you, and it's a privilege to watch you impact people the way you do. So thank you for coming on the show, man. I can't wait to do it again.
Oh, it's a pleasure. We'll definitely do it again. I always have a blast talking with you, Josh. So thank you again for the opportunity.
All right, brother. Have a good one.
Thanks, man. You too.